Assalamualaikum and hello I bid to Professor Azmi, Muhammad Tamil and fellow friends. I'm the representative of Lab 3. Today, we are going to present to you guys our research titled Prevalence of Pre-hypertension and its Associated Factors among second-year medical students at University Kebangsaan, Malaysia. Our facilitators are Dr. Muhammad Fadli bin Muhammad Fauzi and Dr. Nur Adiba binti Mat Saruan, and these are the list of our lab members. As an introduction, hypertension is the most common medical condition seen in primary healthcare setting. It can lead to myocardial infarction, stroke, renal failure and premature death if not detected and treated early, and this is adapted from the research done by James et al. In 2014. Gen C7 report has introduced a new classification that includes the term pre-hypertension for those with BPs ranging from 120 to 139 mm mercury systole and or 80 to 89 mm mercury diastole, intended to identify those individuals in whom early intervention by adoption of healthy lifestyle could reduce BP, decrease the rate of progression of BP to hypertensive levels with age, or prevent hypertension entirely. Based on past 7 years of literature, the prevalence of pre-hypertension among youth ranged between 19% to 68.4%. The lowest was 19.0% in 2011, and we refer to this to set our baseline of hypothesis. Literature showed that pre-hypertension is multifactorial, which includes gender, ethnicity, household income, parental education, BMI, family history, physical activity, alcohol, and anxiety. Literature reviews also showed some findings on impact of high blood pressure. For example, Juan No et al. Found that pre-hypertension patients tend to have higher proportion of comorbidity than normal people without pre-hypertension. Hypertension is becoming an alarming public health problem in our society. To make it worse, the disease is getting younger. Pre-hypertension in young adults is an important risk to develop hypertension in later years of life. Thus, it is important to identify those who have pre-hypertension and intervene early. In relation to problem statement mentioned earlier, pre-hypertension among young people should be identified early. There is an urgent need to identify which factor is significantly associated with pre-hypertension so that the primary prevention specifically tackling those factors can be implemented effectively. These are the questions we wish to answer at the end of the research. First, what is the prevalence of pre-hypertension among second-year medical students of UKM? And second, what is the factors associated with pre-hypertension among second-year medical students of UKM? Generally, we aim to determine the prevalence of pre-hypertension and its associated factors among second-year medical students of UKM. Specifically, we want to measure the prevalence of pre-hypertension and determine the association between socio-demographic factors such as age, gender, ethnicity, parental income, paternal and maternal education, and then health-related factors, that is weight, height, BMI, comorbid, family history, depression, anxiety and stress level, and also lifestyle factors such as physical activity, smoking, alcohol consumption, and drug abuse with pre-hypertension among second-year medical students of UKM. We hypothesized that the prevalence of pre-hypertension among respondents would be around 20%, based on the lowest prevalence rate found in the past 7 years literature as mentioned earlier. We also hypothesized that there is association between socio-demographic factors, health-related factors, and lifestyle factors with pre-hypertension among second-year medical students of UKM. Null hypothesis would be there is no association between all independent variables being studied, namely socio-demographic, health-related, and lifestyle factors with pre-hypertension. This is our conceptual framework. Independent variables are categorized into 3 domains, which are socio-demographic, health-related, and lifestyle factors. Socio-demographic factors include age, gender, ethnicity, parental income, paternal education, as well as maternal education, whereas health-related factors include weight, height, BMI, comorbid, family history, level of depression, anxiety, and stress. Lifestyle factors include physical activity, smoking, alcohol consumption, and drug abuse. Next, we will proceed our presentation with methodology of the research. This is a cross-sectional study conducted in October 2017 at UKM Medical Center. Our target population is undergraduate medical students in Malaysia, whereas our sampling population is undergraduate medical students in UKM. Our sampling frame is the name list of second-year undergraduate medical students in UKM. We include those registered second-year undergraduate medical students in UKM, but exclude those who is absent during data collection. For bivariable analysis later, we exclude those students with known hypertension or on anti-hypertensive drug. Study tools include general questionnaires, which contain socio-demographic, part of health-related and part of lifestyle data. We also use short-form Malay version International Physical Activity Questionnaire (IPAQ) and Malay version DAS-21 questionnaire. Both tools have been previously validated by many authors in Malaysia. We also utilize calibrated weighing machine and sphygmomanometer for weight and blood pressure management. Prior to data collection, we obtain verbal consent from representative of second-year undergraduate medical student at UKM. Next, we distributed questionnaire and we had standard BP and weight measurement. All data underwent validation, cleaning, and coding process. Next, data analysis was performed by using SPSS version 21. Descriptively, continuous data was presented as mean plus minus standard deviation, whereas categorical data was presented as frequency and percentage. Binary categorical data was analyzed by using Pearson chi-square to check for significance of association. Statistical significance is set at p less than 0.05. Based on Joint National Committee 7 in 2004, pre-hypertension is defined as systolic blood pressure of 120 to 139 or diastolic pressure of 80 to 89. Next is operational definition of DAS, where we take the scoring and grading of DAS-21 by Lovibond and Lovibond 1995. This covers 5 categories of normal, mild, moderate, severe, and very severe for depression, anxiety, and stress. This is the operational definition of BMI. Based on WHO classification, by using the formula weight in kilogram divided by height in meter square, we categorize BMI accordingly under these 4 categories that are underweight, normal, overweight, and obese. Level of physical activity is classified into low, moderate, and high based on scoring criteria from International Physical Activity Questionnaire. Next, we proceed with univariable analysis with 156 samples irrespective of non-hypertension status. There are 158 second-year medical students of UKM. 156 of them participated in our research. The response rate is 98.7%. Data is assumed to be normally distributed with 156 samples. The highlighted ones are the highest frequency in each domain. Most of our respondents are 20 years old, female, and Malay ethnic. All of them are still single. Majority of them had family income in range of B40 group. Tertiary education of paternal is the most at 48.1% distribution. As for maternal education, secondary is the most with distribution of 50%. The prevalence of pre-hypertension among health respondents, excluding one known case of hypertension, is 20.6%. Mean weight is 59.2 kg, mean height is 1.6 meters, and mean BMI is 22.5. Most respondents have normal BMI but positive family history of hypertension and diabetes mellitus. Majority of respondents have normal score of depression, anxiety, and stress. Almost half of them has low level of physical activity. Most of them has never smoked nor consumed alcohol in life. No one has ever involved in drug abuse. Next is the bivariable analysis. We took 155 samples as we exclude one respondent with known hypertension. A chi-square test of independence was performed to examine the relation between independent variables and prehypertension. The relationship between gender and prehypertension was significant. Null hypothesis is rejected. Percentage of male respondents who have prehypertension was 51.1%, whereas percentage of female respondents who have prehypertension was 7.4%. The difference in percentage was significant. The relation between level of depression and prehypertension was significant. Null hypothesis is rejected. The relation between level of anxiety and prehypertension was significant. Null hypothesis is rejected. The relation between history of smoking and prehypertension was significant. Null hypothesis is rejected. Percentage of ever smoke respondents who have prehypertension was 57.1%, whereas percentage of never smoke respondents who have prehypertension was 18.9%. The difference in percentage was significant. To summarize, the factors significantly associated with prehypertension in this study were gender, level of depression, level of anxiety, and history of smoking, with p-value less than 0.05. This is another way how we present our data on significant factors, that is, the gender, history of smoking, level of depression, and anxiety. This is our hypothesis conclusion. P-value for gender is 0.000, in which the p-value is less than 0.05. Hence, there is a significant association between gender of medical students and prevalence of prehypertension. Null hypothesis is rejected. Ethnicity, paternal education, maternal education, BMI, family history of hypertension, and diabetes mellitus have p-value more than 0.05. Hence, there is no significant association between these factors and prevalence of prehypertension. Null hypothesis is not rejected. P-value for level of depression, level of anxiety, and history of smoking is less than 0.05. Hence, there is a significant association between these factors and prevalence of prehypertension. Null hypothesis is rejected. As for family history of comorbidity, level of stress, level of physical activity, and history of alcohol consumption, p-value is more than 0.05. Hence, there is no significant association between these factors and prevalence of prehypertension. Null hypothesis is not rejected. As a summary, the prevalence of prehypertension among second-year undergraduate medical students was 20.6%. Factors significantly associated with prehypertension in this study were gender, level of depression, level of anxiety, and history of smoking. This study provides baseline data on prevalence and factors associated with prehypertension among second-year medical students in UKM. And this data can be used as comparison with other population or follow-up over time if intended. Limitations are many other variables have not been explored in this study, such as diet, caffeine consumption, and sleep quality. No causal interference could be made due to study of cross-sectional design. Study only determined association between independent and dependent variables, that is the bivariable analysis, without taking into account the confounding or interaction relationship, the multivariable analysis. The conclusion: there is alarming prevalence of prehypertension among respondents with few significant associated factors such as gender, level of depression, level of anxiety, and history of ever smoking. Further comprehensive study is needed to identify all other relevant factors, such as sleep quality, caffeine intake, diet, and determine appropriate intervention to halt progression into hypertension as primary prevention effort. We suggest for multi-center studies in Malaysia with larger sample size and mixed method to get better precision as well as identifying possible risk factors for prehypertension to enable planning and implementation of better public health preventive measures at all levels. I'd like to express our deepest gratitude to Professor Dr. Azmi Muhammad Tamil for this opportunity. We would like to thank our facilitators, Dr. Muhammad Fadli bin Muhammad Fauzi and Dr. Nur Adiba binti Mat Saruwan, for their guidance and help in completing the research.
We would also thank both Department of Physiology and Department of Public Health for lending us the study tools used in this research. Lastly, we wish to thank our batch in providing cooperation in this study. There is no conflict of interest and there is no funding source. These are the list of references. That's all for now. Thank you for listening.